Mesdames et messieurs, bonjour, bonjour ou bonsoir selon.
Ladies and gentlemen, good evening, good morning, regardless of wherever you are.
Bonjour, j'espère que j'ai votre
Good morning.
attention. Je suis le Laminou.
My name is Haouna Zakou, coordinator of program for Pathfinder in Niger.
Je vous souhaite la
I wish you a warm welcome to share this experience. And so that you understand what's happening in Niger in terms of family planning. So just like other countries that are involved in this project, Niger is dedicated to scaling up contraception practices. And it shows that Niger is committed into the implementation of the 18th session of the session, and to encourage the expansion of contraception practices in African countries. In doing so, Pathfinder has been collaborating with the Niger Ministry of Health through different projects, and especially the project which is financed by the Bill and Melinda Gates Foundation to scale up some services related to family planning on a community level, but also in villages through the distribution of contraception through, on the grassroots level, but also on improving health outcomes, and to bring new contraception methods to youth and women, whether in urban or rural environments. So today's session is the first of a series of 3. There are going to be 3 webinars to share the experience of Niger. And the first one is about the prospect for expanding contraceptive practices through the DMPA and the feasibility, acceptability of injection among healthcare providers and clients in the health districts. So this morning is the first session, and let me introduce our presenters. Our colleague here is a nutritionist. She is passionate about all programs that aim at improving the life of teenagers and youth. She's been working at Pathfinder since 2020. And she is the leader of one of our programs of our contraception project, Access for All to Contraception. And she's been the leader of this project in terms of contraception practices through DMPA self-injection in Niger. So let me introduce you to Laminou. She is going to share with us the experience of Niger about the DMPA-SC. Before I give her the floor, I hope that you are on the right channel. You have the opportunity to listen to this session in English, which is interpreted, but you can also listen to French. So we will be talking for 40 minutes, and we'll dedicate about 10 minutes at the end for Q&A, and to give you, so that you can give us feedback and ask your questions. Now, let me give the floor to Aichatou, who is going to be presenting this webinar. Thank you so much. Thank you so much, Zaku. Good morning, good evening, good afternoon, wherever you are. It is my pleasure to share with you today the information that we have collected in Niger through Pathfinder after the implementation of a project which was aiming the feasibility and the acceptability of the DMPA self-injection among healthcare providers and clients in 2 health districts in Tillabéri and Niamey 4. Next slide. So this is going to be our agenda. So first off, we will provide background information and an introduction of the context. Then we will go over the methodology and how the data were collected. We will also talk about ethical considerations and key interventions so that we could define key findings. And then together we will share some lessons learned and elements of success, but also conclusions. And of course, main recommendations to the Ministry of Health, Population, and Ministry of Social Action in Niger. So let's get started with general information. The project lasted 15 months, started in October 2019 until December 2020 with the financing of UNFPA. The name of the project was Sawki, which means simplicity, which is a local language in Niger. And what were the intervention areas? Those were 2 main areas, Tillabéri, especially Balléyara. And the health center was in Balléyara and Sandire. With regards to Niamey, it's this District 4 that was involved with the Airport 1 and Gankale health centers. So in Niger, the modern contraceptive prevalence increased from 19.7% in 2015 and went up to 21.7% in 2018. And the use of injectables is second to only the estimated demand for oral contraceptives. Let me remind you that Niger, Burkina Faso, and Senegal and Uganda were among the countries where pilot projects for the introduction and initial evaluation of DMPA were implemented in 2014. So it's through those studies that we were able to get conclusive results and to contribute to the introduction of the DMPA in the minimum package of activities in health posts in 2014 in Niger. Therefore, in 2019, the Ministry of Public Health approved the provision of this product to community level through the delegation of texts through community agents. And that's how the Sawki project has been able to test an approach to implementing self-injection of the DMPA that would enforce potential scaling up in Niger health system. What is the main goal here? It was to define the determining factors that need to be taken into account for the introduction of the practice of self-injection in Niger in order to contribute to the improvement of access and use of modern contraception methods for women. So more specifically, it was to describe the socio-demographic profiles of those clients that were recruited for those self-injections, to determine the acceptability rate of those clients, to assess the proportion of clients who mastered self-injection techniques at the first, second, and third sessions, also identify the proportion of clients who comply with the time limit of re-injection, evaluate the waste management system related to DMPA, assess client satisfaction and health provider experience as well, and determine the elements of success and failure to be considered for scaling up the practice of self-injection, which is innovative.
So regarding methodology, we have led a study for 12 months to document quantitative data and qualitative data. And it targeted women aged 18 to 49 years old who go to the 4 health centers that we mentioned earlier and either use DMPA-IM or SC. The goal was to recruit at least 25 clients per health center during the first 2 months of the project, and we have been following up for the next 3 quarters. So what was included in this study? All women aged 18 to 49 years old who were using subcutaneous DMPA or DMPA-IM for at least 6 months, and they were still eligible for DMPA and wanted to keep using a contraception and were living in the intervention area during the implementation of this project. And also they accepted to take part in the study by giving consent. Next slide. So the data was documented through interviews with clients, health service providers also, and we used the supports that were placed at their disposal. We organized also inquiries and surveys of satisfaction, and there were a supervision mission on the ground on a monthly or quarterly basis. So the analysis and processing of data were done by the Pathfinder team. So now let's talk about ethical considerations. We respected all administrative procedures required for the implementation of this project, which were documented. We gave a consent form to all the women who accepted to participate in the self-injection of the DMPA, and the confidentiality and of all the clients was respected, and they were told that they could stop the study at any time. And of course, we have to adapt to the COVID-19 pandemic by protecting providers and clients in different ways. And women from 18 to 49 years old, whether married or not, were included in the project, and they were told they had the right to consent to participate in this project. Next slide. So we organized various activities. During the preparatory stage, there was a visit of the Niger delegation to the neighboring country of Burkina Faso to inquire about how the self-injection of DMPA-SC was implemented. And a protocol of research for this study was approved by the National Ethical Committee for Research in Health in Niger. A technical manager was recruited for the project, and he worked in the health centers that were concerned, and he had experience in community mobilization and family planning. We led information meetings, and we organized also awareness interventions for the project with religious leaders on a community level, and we use various supports to provide it to the main stakeholders. Next slide. So the study was based on 3 pillars: strengthening of capacities and community mobilization. So the health service providers were received training about a self-injection of DMPA, and also on techniques to lead activities and meeting and organize discussions, and also at-home visits sometimes. We placed at their disposal some communication support, the one that were developed at the level of health district, health center, and also for individual clients to help them use this new method. Regarding the second pillar, which is providing the product, the DMPA-SC, so we sent products to the 4 health centers, and we worked with people in charge of the project, and they use those contraceptive products, and we managed not to have any shortage of product during this project. The third type of intervention concerned the supply of services and following up clients. The first stage was to give advice to women coming to this health center to learn about modern contraception devices, the pros and cons. And for women who accepted, who chose to use DMP, self-injected the product, discussed with the health service provider who helped them use this product and helped how to use it. And then we made sure that the clients would agree to the project so that they could indicate that they consented, and we provided consent forms which they signed to show that they agreed to participate in this research. The fourth stage was to develop a test on anatomical models. So the clients themselves administered the product, and there was an observation sheet, and there were visits at home, and also there were telephone conversation to help the women who participate in the project and learn about side effects that could happen. Also, there was a certification process of women who respected the 3 stages of self-injection of the product all along the project. All these women, when they mastered the technique, were able to receive a certification showing that they knew how to use the product. Next slide. Regarding now the main outcome, we show on this slide the number of clients who were recruited, and with 3 blocks. And in blue, we have information concerning clients meeting inclusion criteria for the pilot project. They were identified in the health center in orange, and the women who accepted, who also meet this criteria and accepted AI. So we identified 129 clients, but only 86 were integrated in the cohort. In the Tilaberi region, out of the 89 women who agreed to participate, only 71 were integrated. So we had 218 women who accepted to participate in this research, but only 157 were integrated. And there's someone who are not able to participate in the study because they didn't meet the criteria. Regarding the social demographic profile of the clients, regarding the education level, we can see here in this diagram that most women, 46% of the women did not receive any education. and 28% went to elementary school and 26% to secondary school. 75% of the women taking part in this research were aged 25 or more. Here we see on this slide that out of the 150, all the women, 153 women were married, and 93% of the women were already taking the DMPI. Then we're going to talk about how we followed up with the clients through at-home visit and telephone conversation. We can see here the follow-up in the various quarters. We can see during the fourth quarter of 2019, in Niamey, there were neither at-home visit or telephone conversation. It's only during the first quarter of 2020 that we organized some at-home visit, 187 visits, but no telephone conversation. During the second quarter of 2020, there were no at-home visits, but we conducted up to 304 telephone conversation with our clients. And this result can be explained by the first case of COVID that was recorded in a country. And so they use barrier measures, protection against the spread of COVID. And so we had to limit the activities and at-home visits. So that's why we suspended at-home visit or small group visit, and it was replaced by telephone conversation. During the third quarter of 2020, we started again at-home visit instead of telephone conversation. And what we can say that now the measures, the protective measure for COVID has been suspended too, and we're able to go back to in-person meetings with clients. Next slide. Regarding acceptability of this project by women, we can see on this slide various compartments. First, we see the number of women meeting inclusion criterion who agreed to be part of the cohort. The second block shows the number of women who were affected during the first cycle of self-injection of the product. The third block shows women who were affected, and we see the data concerning the new cycle of self-injection. In blue, it shows information about the Niamey area, in orange in Tilaberi area, and in yellow the total number. So we see that the project started with 156 women who accepted to participate in the study. All these 156 women received their first dose of subcutaneous injection, and in Niamey there were 85 women, and in Tilaberi 71 women. During the second cycle of self-injection, we see a difference because we went from 156 to 139 women. So some women left the program. In Niamey, we moved from 85 to 70, in Tilaberi from 71 to 62 women. So 7 women left the program. This cohort of 139 women remained stable until the end of the project, and all those women received their third dose during the third cycle. So let's take out of this that there is a certain percentage of women who abandoned and left the program, about 7 to 10%. Next slide.
So you will see in blue, which is the collected information on for the first cycle. Now you have the second and the third cycle. So the blue is the first cycle with the results. Orange is the data recorded during the second trial. and the third is dark yellow, and fourth is the light yellow. So the first one, starting with the first trial, you can see that 10% of them have mastered the technique of self-injection. So let's come back to the second cycle. There's a significant improvement because up to 70% have mastered the technique at the first trial. And there were only 3 trials during this cycle. And now let's look at this third cycle. As soon as the first trial, 99% of women mastered the technique of self-injection. So it's just only one woman who did a second trial. So 99% were certified to self-inject the product without the assistance of a provider. Same information on this slide, but it's divided by region with a few more details. So with the first one, with the first cycle, with the first trial, it's the women in Niamey who won. Basically, they mastered the technique right away. Right away, we did not register any information for the Tillabéri region. So you can definitely see some disparities of percentages between both regions. Regarding the second cycle, you can see that the mastering of the technique wins in Niamey with 75% versus 63% in Tillabéri for the first trial. And with the third trial, we notice that all women in the Niamey region, they mastered, it's a third cycle, sorry. So they mastered the technique after the first trial and 98% in Tillabéri. So there's just only one woman who went to the second trial. Now, with regard to the respect of the appointment, respecting the date of the appointment, so 139 women and 96 of them have respected the meeting time for the next injection. And during the third cycle, 81 women. So how can we explain this? So with the health crisis, there was a significant decrease of visits in health centers because of rumors. Let's remind also everyone that because of the safety issues in the Tillabéri region, there was motorbikes were prohibited, and motorbikes are the preferred way of traveling around, of commuting. So that had so this ban on using motorbikes had an impact on the respect of those appointments. This is information regarding side effects. So the first graph shows the percentage of women that showed side effects during the first cycle. So 20% after the first cycle, which came down to 9% during the second cycle and 5% to the third cycle. The second graph shows details per region, and it shows that there were more complications in the Tillabéri region than the Niamey. So the knowledge of women of those clients during the period of protection of the DMPA and the side effects, we recorded that 100% of women know the duration of protection of the product. 100% of them they confirmed that they received information on the side effects that could be related to the DMPA, and 100% of them confirm that they know what to do in case of side effects, what to do, how to behave, and they shared with us that they'd rather go to a health center or contact a project facilitator in case of issues. Now, with regard to the location of injection on the body, those women, whether in Niamey or in Tillabéri, they prefer to do self-injection on the thigh. The second graph shows that only 12% of those women showed they had issues, and most of them are in skin irritation on the injection site. Now, with regards to knowledge on other contraception methods, 100% of them confirmed that they are aware of other contraception methods and they feel free to choose whatever works for them. Now, with regards to the satisfaction of those women with the support of facilitators and healthcare providers, 100% of them are satisfied or very satisfied of the support that was provided to them in both regions. Here, the graph shows the satisfaction of those women during the second and the third cycle. Only 1% during the second cycle. Only one of them showed that the self-administration was complex or difficult to do. And during the third injection, 100% of them thought that this practice was extremely easy. Now, with regards to the perception with regards to self-injection, these graphs show different cycles. So in blue, the ones that were not satisfied, orange, the one that were satisfied, and yellow, the one that were very satisfied. So there were only cases of dissatisfaction, 16%, that was only during the first cycle. We definitely see a significant increase in satisfaction during the third injection. So at first, during the first cycle, they were 8. Second injection 64, and then the third 123 that thought they were very satisfied and they thought this practice of self-injection was extremely easy. Now, with regards to the perception of continuity of this practice, we collected the following data. 86% of women agreed and they were willing to continue the DMPA self-injection program at home after the project. Only one thought that they prefer the injection would be done by a provider. So we just showed you the different results after this experience, but what are the lessons learned? First one, we have observed that the vast majority of women easily acquire the skill required for self-injection after only one simple one-on-one training session, and they retain the skill even 3 to 6 months later after their first self-injection. So self-injection is easy and affordable for women in both rural and urban areas. And the second point is that the lack of education or the age are not barriers to understanding or mastering this self-injection amongst women. Thanks to the demand creation mechanism that was implemented during the study, we were able to remove barriers by building women's confidence. And this allowed us to enroll way more women than we were expected, especially in a very short period of time. So the COVID-19 pandemic adaptation plan put into place by the actors allowed the project activities to continue to be carried out in a very secure environment while guaranteeing the protection of communities, the people that benefited from the service, the health providers, and also the staff. We also observed the community and health worker buy-in to this strategy, thanks to the communication mechanism and the supportive environment that we provided through this project. And so the regular follow-ups through on-site visits, at-home visits, and phone calls helped this whole project. So as conclusions, let's remember the following. So out of target of 100 clients, 150 clients were enrolled during the first 2 months of the project. They were trained and they all 100% passed their first self-injection with success. And the 139 women that received their second dose by self-injection, only 17 exited the program. And 99% of these women mastered the technique of self-administration after the first trial, and those were satisfied to administer the DMPA without the assistance of a provider. 54% of the clients were very satisfied with the facilitators and the providers' program and help and support. And 60% of them were also very satisfied with the facilitators and the provider's support during the administration or the self-injection procedure. Now, the social mobilization that happened at all levels has helped to create a favorable environment for the implementation of this project. So what are the recommendations that we provided to the Ministry of Health Services, the Population and Social Action? We want to explore data from other studies in Niger and other countries in Africa on self-injection to develop a community-based waste management system for scaling up. We also want to make this environment conducive to self-injection for the success of the program through advocacy to prepare all stakeholders, the training of health providers, supply the products, the DMPA-SC to health facilities, but also by setting up a system for creating demand, a mechanism for monitoring clients and monitoring the quality of services. So here, this is the image of the certificate that we obtained. So we provided all the data of this project to the and we got the gold medal basically for this project. So thank you so much. This is the end of my presentation to share the experience of Niger with the experience of self-injection of DMPA. Thank you so much. Thank you so much for this remarkable presentation. You shared with us how this pilot project favored the acceptability and feasibility of self-injection with, directly with women, but also for the health services, health providers. And the conclusions show that this self-injection is very possible. It is very satisfying. And the information show the capability of scaling up this project. The results from this experience are already being used as guidelines for the ongoing for the ongoing conversations happening at the level of the Ministry of Health in Niger. Thank you so much, and thank you so much to all of you for your attention. Now we are going to move on to the question and answer session so that we can receive your questions, your comments. I've already read 2 questions that were posted in the chat. So for everybody, here's the question from Patrick.
Are you going to share the video after the meeting? Yes, we will share with you all the materials and the video, other documents that are required, and it will be useful for you to receive more information about this beautiful project in Niger. The second question I saw, it was in English, but other participants may ask other questions, and we will maybe ask Aichatou to answer the first question. It's a relatively simple question, and maybe we will ask you to talk about the sample that was used for this study. And then in the meantime, please prepare other questions. Aichatou, you have the floor. Thank you very much, Zaku. Well, so the question was about the sample, sampling. What is the sample that was used? So as we saw it in the presentation, the project used a 100 women sample, so 25 women per center, and there were 4 health centers that were chosen. So there were facilitators who were identified in each center, and all the women who met inclusion criteria and consented were recruited until we reached a number of 156 women. This is how we organized our sample based on our goals at the beginning of the project. And now we stopped recruiting more women, and we kept working with the clients who were selected for the first and second stage of the project. Thank you very much. Now, do you have other questions or other information you would like to share? Or we have one question here. Which strategy did you put in place to provide the supply of inputs? Go ahead. Yes, there were 2 strategies that we used. The first one meant we created a stock of product in the various health center. We know that those centers order product on a monthly basis, and we made sure there wouldn't be shortages during the project. We wanted to have a sufficient number of products for the beginning of the product. And also we facilitated the recruitment of local facilitators so that they could help us organize this, create this stock of contraceptive product. And also we did a follow-up of the supply process to provide any risk of shortage during the implementation of the project. So this enabled us to do what I said. And again, there was no shortage of product on this level. Thank you very much. I see another question. Mr. Babi Mamadou, who said, you talked about inclusion criteria for the recruitment. What was the impact of the lack of security? Okay, the impact of the lack of security, as we saw in the presentation, was felt mostly regarding the fact that women sometimes have trouble to go to meetings. So what we do in Tillabéri, many women could not go to the health center because they didn't have ways to go there to receive their dose, but the facilitators helped, reminded them, and could help them find ways to go to the health centers and have more confidence in the ways they could use to go there to receive the product. So the lack of security was mostly a problem in Tillabéri, and this was an impact in the Tillabéri area. Thank you very much. Do we have other questions? We still have a few minutes. Okay, I also have some additional information to share with you, since there are no other questions. We can share that with other participants who are online. No, I want to thank all the participants, and notamment to listen to me when I shared the outcome of this experience. And if, in case you need help, need additional information, you will receive them. If they want to implement a similar project about self-injection of contraceptive products, so we'll be very happy to share all the information we have. Thank you very much, and we'll answer a last question in French. I hope I didn't miss any other question. So, are there opportunities to collaborate with other partners? And I think this is connected to what you said. It's a question from Mr. Mamadou. Are there opportunities to collaborate with other partners? Yes, absolutely. As I said, we are ready to help to provide technical support for this type of intervention. We are available, and we'll be ready to help in this way. How did you manage the issue of waste management on a community level? Thank you. So regarding this, unfortunately, the project was not able to document this issue, and this is one of the recommendations that we made to the ministry, is to discuss with other partners in Niger who had organized this kind of study, or in other countries of Africa, to prepare a system that would resolve this issue. Thank you very much. So please keep sending questions. We will answer them after the end of this webinar, and we will be available to collaborate with you in order to provide more information on details of the implementation of this experience in Niger. And these results were made possible thanks to the collaboration of the Health Ministry, with which we collaborated. Thank you very much to the Minister, and also UNDP and other local organizations, which enabled us to reach this goal. And I want to thank you, all the organizers of this session here in Niamey and in the United States, to make sure that we can communicate and exchange information in the best possible conditions. I would like to end by telling you that we would meet again on Wednesday, May 25th at the same time, 2 p.m. Niamey time, for our next webinar about delegation of tasks and introducing explanation and information about implant long-lasting implants. Also, we'll have another meeting on Tuesday, May 31st, session of sharing experience of the supply of DMPA injectable by community distribution agents in villages. Thank you very much to all for your availability. I will say good evening here, or have a good day, depending on where you are. Thank you to all.